There's a bunch of new products coming out that are directed directly to emergency medicine. In fact, emergency medicine in the hospital setting is the only place that they're directed. And there's going to be people coming down into the department that want to talk to you about these wonderful things. And actually, some of them are pretty wonderful. Those of you who get the throwaway magazines, the ASAP Now and those kinds, you see these full-page ads for these little EEG machines on your head. There's a couple of those. There's also full-page ads for the brain injury test, which is a blood test that was developed by Abbott, runs on the iStat machine. How cool is that going to be? Well, we got some data on it. The first machine is called the Brainscope. It's $15,000, and they claim it'll do three things. It'll do, number one, it'll tell you if you have an intracranial hemorrhage. Number two, it'll tell you if you have a concussion. Number three, it'll tell you if you have a stroke. I thought it was a pretty good thing for $15,000. Now, obviously, it is not as good as an MRI, and it's not as good as a CAT scan, but I'll show you where it comes into play. Both of these instruments, the Brainscope and this other EEG device, are going to talk about saving you doing CAT scans. And they come up with some interesting dollar signs here. In any case, let's look at the first article here is really not an article. It's a letter to the editor written by a physician who's involved with this Brainscope project to the American Journal of Emergency Medicine about a little survey, a little product evaluation that they did. They had 91 adults who had bumped their head. It says in traumatic brain injury. I don't know if you can really use that term. How about it just bumping their heads? And they show up in the emergency department, and all of them had a Glasgow Coma score of 15 except one person, so not too bad. And they all had a Brainscope EEG done. And the authors state that 78 CTs were negative. 78 CTs were negative. And 28 patients were identified for of the 78 people who had negative CT, the Brainscope was negative in 28 of them. So the Brainscope said, you don't have something wrong in your CT. A few people who had positive Brainscopes certainly did. So these people then said and back calculated and said, well, listen, we've determined that 31% of people who have negative CTs, if they have a negative Brainscope, you don't need to get the CT. So the idea here is, well, you save dollars ordering 31% less CTs, and that is worth $76.5 billion. So that's what we're going to save the country, $76.5 billion, because you're going to get this little EEG. The little EEG is negative. That's going to say the sensitivity specificity for that is really, really good. It's not 100%, but it's like 98% sensitive in picking these up. So it presents the opportunity for a whole different paradigm about how you go about ordering these tests, which we don't need. Because one of the scallywags who talked about this is, well, so many of the CTs we're going to be ordering are going to be negative. As an example, in that case, 78 CTs were negative. Does that mean that the other 23 were positive? Not necessarily. Maybe they were not injured enough to even warrant a CT. So we're going to go to another paper that also shows we're doing a huge number of CTs, and if you just said negative, 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 you would be right the vast majority of the time without even knowing anything about the patient, because we order so many negative CTs. So the 91 patient study was looked like an appetizer. Now they get into the real McCoy. This is a study of 720 patients, and this is where they're looking for, remember they do three things: bleeding, concussion, and stroke. So in the bleeding paper, they basically looked at 720 patients with traumatic brain injuries. This is a multi-center study to find that many people. They're not very good on things like methods. When were the EEGs done? Who did them? Who read them? What was considered a positive? This whole list that's there. Well, anyway, 11 emergency departments got together and came up with these patients. It was funded by Brainscope and the Army. The Army and the feds are interested in determining whether you have a concussion, whether you need to have a CT or not. And the idea of having some ability to have black and white data about a concussion rather than just symptoms. Here's the symptoms. Oh, you probably have a concussion. These are symptoms of a concussion. No, they basically show you've got brain things going on that are not normal. These are consistent with a concussion. So the idea of having something much more measurable appeals to people. In any case, 720 subjects who bumped their head. 97% were Glasgow Coma score 15, so we're talking about, not much in the way of head injury here. And the idea was CTs were ordered in 73% of the people. 27% of them didn't get CTs. CTs were ordered in 73%. Now, how did they follow the people that didn't get a CT who bumped their head? They gave them a phone call a couple days later, and if they answered the phone, they assumed they were alive. And if they didn't answer the phone, they assumed they were dead. But this is a typical, there are 25% of these people who bumped their head didn't even need a CT by the judgment of the doctors. 73% got the CT. And how did this test do? Well, the CTs were read, in this case, centrally by not each individual hospital. They took the CTs and sent them to the central group of radiologists so that there was consistency in the determining of whether there was any kind of bleeding in the head. 20% of the EEGs were considered unreadable. Okay, throw those out. 20% of the EEGs were unreadable. And that left, of those that were readable, the sensitivity for bleeding in the head was 92%. 92% bleeding in the head. Specificity was really good. And when they tweaked their algorithm a little bit, they got up to a sensitivity of, where is it here? I think it was like 99% they got up to by tweaking the algorithm into an algorithm that said yes, maybe, no, versus a binary algorithm that said abnormal, normal. I think that this paper basically would make you feel relatively comfortable doing a Brainscope scan first, and if it's negative, you don't need to do the CT because the sensitivity was basically it basically won't let you down. There may be a rare person because it's not a study of 5,000 people; it's a study of 720 people, and so there may be some small errors in there. But they like the idea, negative Brainscope, no CT. And who knows, we may transition to that because obviously it's going to save the insurance companies some money on CTs if we, as emergency people, feel comfortable that's true. And so the data really is pretty strong. We tend to take a look at these new tests and kind of poo-poo them, but this is a big deal, I think. The hospitals aren't going to like the idea that you're going to 30% of your CTs are going to go away. Everybody's got like a different point of view about who's got the money. Abstract number 3 is about concussion. Now that's really interesting stuff because the Army wants that, the football players want that, all of the injury on the field, they want that. You got your bell rung. Do you got to go to the hospital for a CT or do you not? Can we do this test here and make a decision? And the answer is, appears that way. Because if you're doing a CT in the setting of somebody got their head bumped, and they had a concussion, maybe they were knocked out a little bit, The only thing the CT is going to tell you is whether you got any bleeding. And so, but it's not going to tell you whether you have a concussion. This machine will tell you whether you got a concussion. They came up with what they're now selling as a concussion index. Prior to that, they had a thing which they called brain function index, which transitioned into being called concussion index because you could sell more machines with that than brain function index. And what was going on in this study? This is number 2. And they're looking to see whether this machine can do CT positive head injuries. We'll find those. CT positive head injuries, we'll find those on the Brainscope. We'll find basically those with concussions, which have a negative CT but concussion. And thirdly, we'll find those who have a negative CT and a negative concussion as determined by this EEG. So the idea of you don't need to go. You don't have a concussion, and you don't have a need for a CT. And that could be determined on the field. Not that you would necessarily go into the next play, but it's like it makes a decision. Do I need to take them to the emergency department for a CT of their head after this whack? And these guys say, take a look at this. The sensitivity and specificity really good, and maybe not. One of my friends is the chief doctor for the NFL Players Association. And I asked him, are you guys into this? Because this is right down your alley. And he said, we're not ready to deal with this just yet. There's all of this stuff about this traumatic brain injury that these folks get over time from repeated blows to the head. So there's a path here that is very, they're going to try to be very, very careful about it. In any case, what do we do here? All right. So this is the one where we're looking for concussion. 720 patients again, the EEGs, and then that 720 patients again was sampled, looking for evidence of a concussion. Using complicated EEG and mathematical analysis, even the other one says we use something called artificial intelligence to come up with this stuff. They came up with the 3 groups. The 3 groups were no impairment, moderate, meaning likely to have a concussion, but its CT is going to be negative, and those that are going to have a positive CT. They came up with those 3 things with very high statistical differentiation. They concluded device-generated brain injury that has the potential to aid in early diagnosis of traumatic brain injury. The 4th paper is about the 4th abstract is about the 3rd thing they say they can do, is they can help you define people who have a stroke, particularly in areas where your CAT scan access is not that good. I mean, when Ken talks, his little hospital where he was didn't have a CAT scan machine. So maybe getting this $15,000 job may help him out a lot. Anyway, this is an abstract number 4. They're looking for brain strokes. The highlights, 48 patients with stroke patients and 135 stroke mimic patients were put through the Brainscope process. The device was 92% sensitive, 50% specific for a stroke, 92%. Through measuring brain waves, they've got these algorithms that say this is what it is. Now, when the initial CT was negative and these people still had a stroke, which is very common, the sensitivity dropped down to 80% in saying you've got a stroke. But that's still, if you have somebody who has a stroke and you order CT, and the CT is negative, they're still in the stroke pathway kind of thing. And, so this basically said, you don't have to call the helicopter in necessarily to transfer this person because the device is 92% that you do not have a stroke. You have a more likely to have a stroke mimic. So now, urgent care centers are buying this machine and advertising. In there is the script that the urgent care centers are using. Is it a concussion? Find out fast. A brain injury needs prompt diagnosis. I think I like this one. That's why it's important to get any head injury checked out, even if you think you're okay. Even if you're thinking of getting a head injury tomorrow, you better get in here today and get checked out. And one of the big things is that you'll reduce the waiting time, expense, and stress of a typical ER visit. The world thinks of an emergency department visit is you're going to wait, you're going to pay a lot of money, and it's going to be stressful. That's the image we've created over the last 30 years. Everybody's trying to reverse that image. Oh, the door-to-doctor time now is 15 minutes, et cetera, et cetera. But you ask anybody out there, what do you think in the emergency room? They say, I'm glad it's here, but the urgent care industry has lived on our droppings because we were just too busy. We couldn't handle it. So the urgent care said, you don't worry. We'll take care of your patients that you're not able to handle, and we'll do just fine. Thank you. So anyway, I think this is a big marketing device now for these urgent care centers. Brainscope, it even has a nice tone to it, word. Come on, get your Brainscope here. We're giving a special on Saturday morning kind of thing. Bring the family. If anybody's acting weird in your family, you might need a Brainscope kind of thing. I can just see this, wonderful. And then the next one's another EEG thing. The next one is only interested in determining if you have non-convulsive status. That's the whole thing that this thing does. That other thing, there's three things. You would think that the other thing that there's three things, they would buy the license and say, let's do all four things. We'll tell you whether you have status, as well as bleeding, as well as concussion, as well as stroke with the other one. But this one does. And the bottom line is, you and I don't know how to read EEGs. They put this thing on your head, and they say, well, some of these people have non-convulsive status who are unconscious, and you don't really know what's happening. And it's important to determine whether they have non-convulsive status because it may have long-term, intellectual process issues. However, for the last 40 years, they must be having a lot of cases of non-convulsive status because we never made the diagnosis like they say we should be because there's a study here. 149 people with altered mental status. Half of them cared the usual way. Half of them cared for with getting the Cerebell. Great name, Cerebell. Cerebell. And so half of them got the Cerebell test. And how many of them had non-convulsive status on these altered mental status patients? 5%. 1 in 20 had non-convulsive status. Which means if you would treat them, then give them some diazepam or the like, that it would stop and this bad process in your head, or potentially bad process in your head, would stop. It's something like, well, we never knew it before, we never did anything about it before, and we didn't know whether it affected the outcomes of what we were doing. But in any case, that's what they said, 5%. And when they looked at things like ICU admission, mortality, ED length of stay, they found no difference whether you had non-convulsive status or not. So this is trying to function on the intellectual level about how's your brain going to work. About a quarter of the patients had a history of seizures or had a seizure at the time of their beginning of their spell of altered mental status. The authors conclude bedside mini EEG is feasible and can affect clinical management. They asked the doctors, well, would you do anything different? And if you look at virtually every number in this paper, they said about 50% of the cases, our management was changed or our testing was changed. 50%, yeah, it was like 50% of those people who had a positive EEG, it was changed in, but all the others, or you can take it the other way. We did this Brainscope on every one of these, and we found 5% who had a problem in their head in terms of a seizure, and all these others. So they say, we changed management? Yeah, this person didn't have a seizure, this person didn't have a seizure, this person... We never even thought of them having seizures in the first place. But they're taking a lot of credit for changing what we do. All right, moving on. Now, oh yeah, we're getting there. Hang in there. So they gave this Cerebell machine to 5 neuro ICUs to use, where they have neurologists and neurology fellows there, and all physicians, yeah. Primary outcome was change in physicians' sensitivity or specificity for seizures, and it's an EEG machine, so it had 37 physicians evaluating 181 patients, and basically the physician's sensitivity for seizures increased from 78% to 100% because the machine, you said, you got a seizure here. Now, the use in the emergency department is going to be a problem because we don't know how to read the EEG machine. So what they did is, and this is fascinating, abstract number 7. So the guy who basically invented this thing is at Stanford, and he hooked up with a guy at Stanford, or a woman, I don't know, frankly. And so the neuroscientist at Stanford joined up with a composer cellist who runs the Center for Computer Research in Music and Acoustics. The Center for Everything now. And the two of them got together, and what they did is they made the output from the EEG machine sound. And when you have a seizure, you have a unique sound pattern. When you have a seizure, the unique sound pattern, they can make a sound. So maybe it's a sound that is easily appreciated. Well, that's exactly what they did. They took 34 medical students and 30 nurses and gave them a 4-minute training. Here's the sound. Here's how you identify the sound. And then they stuck in all of these 84 EEG samples were sent in with seizures, seizure-like illness, 53 normals and slowing. They gave them a test-like kind of thing. Novice sensitivity for the seizures, identifying these non-convulsive seizures was 98%. 98%. Compared to 88% of the neurologists who are looking at the screen. The sound was better than the screen. The sound was better than the neurologists were. So now that you get this machine, you plug it in, and so it's going to be like a bird chirping. I hear it, and that person you got now is having non-convulsive status. Your whole department learns how to listen for this sound. It's another sound that's going to be permeating through the emergency department. Number 8, does it work in the emergency department? 2 EDs documented their experience using the Cerebell in 38 patients. They got 2 EDs, 38 patients. It took them 6 months. I mean, that's like 19 patients, each ER, over a 6-month period of time. It's like, didn't sound like they used it very much. Well, they're really looking for people who have altered mental status, who don't respond to Narcan, who don't respond to glucose. We don't know why they're down. Maybe the CAT scan is negative. It's like, what's going on? So these guys basically say, we didn't find a lot of people who we think qualified for this test. And the rest of them, I think we knew what was going on. The primary outcome was the proportion who got a change in their diagnosis, treatment, and disposition. And it's always the same, 53%. change in clinical management, the rapid EKG. At the site where emergency physicians used sonic reading, 13 of the 14 interpretations were confirmed correct by EEG. So they missed on one. 13 of the 14 were correct. And in this whole study of 38 patients, one patient had non-convulsive status. 1 out of 38, So we never diagnosed it for 40 years, and now there's some cases that have it. You're probably doing the patient a favor if you interact. Interosseous drilling for epidural hematomas. We'll skip that. You see the picture? You see the TT? You drill a hole. You use your IO device, make a hole, suck out blood, become a star, save a life. All that, we'll just skip that. Oh, the last one. Geez, where did the time go here? This other one is a blood test this is the Abbott blood test for brain injury. And the idea here is also to obviate the need for CT. If your brain injury test is normal, then you don't need a CT. It's basically what they're going to tell you. And actually, they're going to prove it to you. This first paper, so it runs on the iStat, but it's not the test was developed by another company. They developed it and said, here, run it on the iStat. And it's 2 brain juices that they're measuring. This glial fibrillary acetic protein, fibrillary acetic protein, GFAP, and ubiquitin C-terminal hydrolase L1. And these are 2 brain proteins that come out when you injure one is from the astrocytes and the other is from the neuronal body. And together they put an algorithm together that says, measuring this and measuring that, we combine them and basically tell you whether you have a brain injury or not. The test that went to the article that got to the FDA that gave them the license to say you can run this now is 11A. This is in your addendum. Somehow this got screwed up, but so you have an addendum there. I can just summarize this little bugger for you. It's the trial is called Alert TBI. 2,000 adults with non-penetrating traumatic brain injury were looked at. 93% had a documented Glasgow coma score of 15 or better. So, or there is no better. But this is all mild head injury. Of the 1,900 people that were entered in this study, 125 had traumatic brain injury. Traumatic brain injury identified on neuroimaging. So that's what we're looking for. Now, 125 out of 56 is 6%. So 6% of the population who bopped their head here basically had a positive scan. Of those positive scans, 8 of them required neurosurgical intervention. That was 8 out over 1,959. So it's a really tiny amount. That is for sure. I didn't calculate that percentage. So of the 125 people who had traumatic scans, the brain scan was negative, they looked at this blood test, and there were 3 who the blood test missed them. 3 were the blood test missed them. So the blood test was 97.6% positive. The blood test is positive. You bet your money that this person's going to have an abnormal CT scan. What's on the other converse? What about the people who had normal brain scans? How many of them had an abnormal blood brain test for injury? 0.4%. So it kind of worked on both sides of the equation. If you have a negative CT, the blood test should be negative. Will it occasionally be positive when you have a negative CT? Occasionally, rarely. There's no 100% here. But this is another one. If the test is negative, likelihood of you having anything at all on your CT is zilch. This people doesn't have to be taken from the football game. They don't have to have it in the emergency department. This is another group that says we can cut down your head scans a lot. Ryan's Radecki or Radecki? Yeah, Radecki. He's a smart guy. He writes all of these very criticisms. This was from ACEP Now, where he did this critique. He's from New Zealand or Australia, I think New Zealand. But basically he said, look at all these negative head scans in the first place. Why don't you just try using the Canadian head CT rule and you'll save yourself, 40% of the CAT scans that you're ordering, which are, a whole lot. Use something simple. That doesn't cost anything. You don't have to do this $100 blood test. You can just look up and put it into, what's that MD Calc? MD Calc will tell you the answer rather than having to do anyway. So both of these tests are going to be down your throat in terms of being monitored, being offered to the emergency department, saving you a lot of potential CAT scans and helping you quantify whether a person has a concussion when you weren't able to do that before except by using some symptoms. So this is kind of interesting stuff, I think. And I think that, have anybody here bought any of this stuff yet? Well, your local urgent care have got 3 of them, because they want to compete. You don't want to go to that ER. Just come with us. We'll check out your head. They'll probably get the traumatic brain injury blood test from Abbott. There'll be a neuro center urgent care. But nobody's got been sold any of these things. That everybody come to you, tell you about this machine and these machines. 0? Well, if you look in ACEP Now or any full-page ads, that's called a giant ad. Those ads are about $8,000 a piece, and they've been running now for, 6 months. I'm surprised that none of you have been approached yet.